Okay, so now we're going to talk about our respiratory gram-negative rods. And before we talk about our gram-negative rods that cause respiratory infections, we have to visit meningitis. And so you might ask why, but it's because these particular infections, some of them are associated with causing brain inflammation or meningitis, inflammation of the meninges. So your meningitis is going to be a infection that is able to get access to the cerebral spinal fluid. So you're going to get infection of the cerebral spinal fluid, and this leads to inflammation of the meninges, the membranes surrounding your brain. And some of the early signs of meningitis are going to be a stiff neck. You're going to have neutral rigidity, severe headache. It's associated with a bacteria infection, so that's going to lead to a prodrome symptoms, chills, fever. In the late stages, you're going to start to get mental confusion, stupor. This can lead to a coma. And these can be caused by different types of pathogens. Meningitis can. So if you're going to have a rapid onset, this is usually associated with bacterial. If you have an acute aseptic, meaning you don't have any pus present and you cannot culture the bacteria, this is most likely going to be viral. And if you have an insidious onset, insidious means slow. So that's what insidious means. This is typically going to be a fungal cause for meningitis. Now, for bacteria, some of the causes of meningitis are going to be bacteria we've already discussed. We have our strep species that can cause meningitis. Strep pneumoniae, for example, is a more common cause. And then we also have Listeria that can cause meningitis. For today, we're going to talk about Neisseria and Hemophilus causes of meningitis. There are also fungal that can cause meningitis as well as viruses. The enteroviruses, those are the ones like polio, are going to be the most common cause of viral meningitis. Now, one of the things that's important for our bacteria friends that cause meningitis are going to be the polysaccharide capsule. So the polysaccharide capsule is going to have some properties. It's going to be antiphagocytic. It also will define what type of bacteria is causing the infection. You can actually detect the polysaccharide antigen in the spinal fluid, and it is the target of the vaccines used for these bacteria. Now, meningitis is considered a medical emergency. Your meningitis requires rapid diagnosis to begin antibiotic treatments. So you must begin antibiotic treatments fast. Especially if it is a bacteria, because our immune system will clear a meningitis caused by viruses, but it will not clear meningitis caused by bacteria fast enough to save the individual. The mortality rate is going to be about 15 to 25%. And even with antibiotic treatment, you can still have death associated with meningitis. And we're also going to have complications. And these are going to include hearing defects and mental retardation, some sort of damage to the actual brain. Now, your diagnosis is going to be based on clinical symptoms, also a lumbar puncture in which you actually are going to harvest or grow the bacterium culture. You can also take a blood culture to look for certain bacterium or agents that can cause meningitis. Now, so let's talk about a few of these guys. We have Hemophilus influenza. So Hemophilus influenza now has a vaccine. It used to be a leading cause of meningitis, especially in at the teenage age. And because the vaccine is no longer a prevalent cause of meningitis, it still can cause meningitis in children that are very young. And typically it's a Hemophilus species that's not included in the vaccine. It is a facultative gram-negative short rod. It's called a coccobacillus. It's fastidious, meaning that it requires certain proteins in order to grow in culture. And so the requirements for this is going to be heme, the presence of heme in the culture plate, as well as NAD, vitamin, niacin. It's going to normally inhabit the upper respiratory tract and the ornopharynx, and the transmission is by exchange of respiratory and throat secretions, so close contact, sharing, kissing, sharing drinks, etc. Now, its virulence factors is it does have that capsule, which is the target of the vaccine. It also is a gram-negative, so it always has the endotoxin, and this one also has an IgA protease, and that's important because immunoglobulin subtype A is going to be important for protecting mucosal secretions from infection. And so since this is going to be introduced in the upper respiratory tract, IgA can neutralize or help to control this infection. So by having that protease, Hemophilus influenza is pretty much eliminating the IgA effect. Now, the infection is going to be either invasive, meaning that it gets access to the blood and you get sepsis, and then this will lead to meningitis. Or it can be respiratory. It can be localized in the respiratory, and there you get a sinusitis, pneumonia, or an ear infection. Respiratory can be treated with ampicillin. You're more invasive. You have to get a treatment that can cross the blood-brain barrier, and so you have to use a different type of antibiotic. Prevention, of course, is going to be a vaccine. So this is a conjugate vaccine in which the capsule is linked to the diphtheria toxin. So it's a combination of the two. Now our next guy is Neisseria meningitis. Neisseria is a facultative gram-negative diplococcus, and this is oxidase positive. So oxidase is a very fast test. You can basically do it on a filter paper. Neisseria is also going to be able to ferment glucose and maltose. The exception is Neisseria gonorrhea that ferments glucose only. These guys are going to inhabit the upper respiratory tract, the nasopharynx, and anywhere from 5 to 35% of the individuals in a population are colonized with Neisseria. Transmission is similar to Hemophilus influenza, in which you get exchange of respiratory throat secretions, coughing and kissing. Just breathing exhaled air is not enough to transmit Neisseria meningitis. And then also you have individuals who have a deficiency of complement, especially that membrane attack complex. And this is that C5 to C9, complement coated C5 to C9, which punches holes in bacteria. And so if you have a complement deficiency, then recurrent Neisseria meningitis infections occur, and typically that will present early in life. They have virulence factors, so they have pilus, which can help to adhere. They have a capsule. There are 13 different serotypes of the capsule. Groups A, C, Y, and W135 are the most common found, so all of those clumped together are most common. Group B, however, itself is very prevalent. It's isolated about 25 to 35% of all cases. And this is just an image of the bacterium with that capsule. They're also a gram-negative, so they have that endotoxin again. They also have an IgA protease similar to Hemophilus influenza. Now, Neisseria meningitis, there is a vaccine. There is a vaccine that is MPSV4, which is a polysaccharide of a capsule. and this is used for patients over the age of 55. It's not used for patients under the age of 55. There's also capsule conjugate vaccine, and there's two versions of this, and both of them can be used for people who are between the ages of 2 and 55 years old. However, in all of these vaccines I just mentioned, they are not protective against serotype B. There is a vaccine that targets serotype B. One of the reasons you cannot use a capsule associated with serotype B is because it is closely related to the glycoproteins in your brain that have sialic acid on them. And so you get cross-reactivity of the antibodies generated to serotype B with those proteins in your actual brain. And so the group B vaccine is targeting 3 different proteins as well as a membrane vesicle. So the 3 proteins are factor H, our Neisseria adhesion A protein, Neisseria heparin binding antigen protein, and the outer porin, pore A. And so all 4 of those are included in the Bexsero group B vaccine. Now you can treat meningitis. It is susceptible to penicillin G, and so you can give that for a treatment. You also have the ability to do a chemotherapeutic treatment, so chemoprophylaxis treatment, if you would, and those are from rifampin, ciprofloxacin, and ceftriaxone. Now, the only one that's important to note here is that you can't use rifampin in pregnant women because it's teratogenic, which means that it can cross the placenta. Neisseria meningitis also does not have much resistance, so penicillin G works very well against this particular bacterium. Now next up is our Bordetella pertussis, which is a gram-negative coccobacillus again. This guy again is going to have an endotoxin because of gram-negative. It is the causative of whooping cough, pertussis. So this Bordetella pertussis is going to colonize the upper respiratory tract in humans, and transmission is via respiratory droplets. It is very contagious. So if you have an individual in a family, in a household who has the infection, 90% of unvaccinated children living with that individual will become infected. If you have an infection at a daycare, 50 to 80% again of unvaccinated children will become infected at that daycare if they were exposed. The virulence factor are very similar to what we've already been talking about with this group. It has pilus in order to bind to our cells. It has a capsule, an endotoxin, and an exotoxin. Bordetella pertussis toxin is going to kill ciliated cells. So you can see in this bottom picture here, we have a picture of the ciliated cells with our bacterium attached, and Bordetella pertussis toxin kills, so PT pertussis toxin kills our ciliated cells. And this is important for it to establish itself and also to cause the disease. Now, our diagnosis is going to be based on a few factors. Pertussis, of course, whooping cough has a series or a progression to the actual disease. But in order to diagnose it, coughing alone is not sufficient. There has to be something else associated with it. And so you have paroxysms of coughing, and the paroxysms of coughing just simply means the cough is in rapid succession. So that's a paroxysm right here. So you have rapid coughing. So you have to have coughing with at least greater than 14 days with this rapid coughing paroxysms, or you can have coughing greater than 14 days with inspiratory whooping, and that means when you take in a breath, you make a high-pitched sound. It sounds like a whoop, and so that's on the intake of air, not on the exhalation of air. And then you have post-tussive vomiting, which basically is vomiting that usually is associated or follows forceful coughing episodes. So all three of these, at least two of those have to be present for whooping cough diagnosis. Now you're going to take nasopharyngeal swabs or aspirates and then culture, and you can do PCR and serology also on to clinically diagnose this. The stages of Bordetella pertussis are shown here. You have, of course, your incubation period, and then these are in weeks. So your incubation period could be as much as 2-3 weeks prior. So this is insidious onset, which means slow. And then you're going to have the period that follows that, which is the catarrhal stage, and this can last a few weeks. So here it's showing 2 weeks, it can be 3 weeks. And here you're just going to have a runny nose, you have a slight cough, maybe a fever, nothing really to tell you that you have your pertussis infection. You can have coryza, which is basically a catarrhal inflammation of the mucous membrane in the nose. And this, again, is not specific for whooping cough. This can also be seen in patients with hay fever, for example, or with colds. So in this catarrhal stage, it's still very non-specific. And then you go into the proximal stage, and this, again, can last for several weeks, 1 to 6 weeks or up to 10 weeks. And this is where you get your symptom or your coughing that is associated with pertussis, where you get your rapid coughs, you get your paroxysms, etc., and that's all in that proximal stage. And then finally you go into your recovery, and again by weeks it takes time to recover from a pertussis infection. So one of the things to keep in mind with Bordetella pertussis is that the upper respiratory tract of adolescents and adults serve as a reservoir for transmission to younger children and infants. And most severe disease is going to be seen in children and infants, especially those less than 6 months of age. Now, Bordetella pertussis is not invasive. It does not enter the bloodstream. And so treatment is going to be with an erythromycin, for example. So again, prevention and treatment. So in the past, the pertussis had inactivated whole bacteria in the actual vaccine, and the side effect of this was an encephalopathy out of 1 out of every 1,000,000 doses. So this is no longer used in the USA. Instead, we use now a DPT vaccine, which has an AP version of the pertussis, which is an acellular pertussis. All this means is it's made up of proteins and not the bacteria. So for Bordetella protection, you need 3 doses of the DPT vaccine. The first dose is given at 2 months. It's followed by another dose about a year of age. And then about the time they go to school, they get their 3rd dose. And then, of course, just like adults, because of tetanus, the boosting with this and pertussis is every 10 years about. You get a booster of this. And then the treatment can be with erythromycin, or we can have azithromycin. Now, pertussis, it's important because most infants, half of all infants that get the disease, they got the disease from their parents. So it's important for you to keep up your booster shots, especially if you're around young children.